Okay, so I am going to talk to you about vomiting in the newborn, right? So when we talk about vomiting, it actually includes two things. Parents will maybe seeing it as the same thing, but we need to differentiate whether it is regurgitation or whether it is vomiting, right? So spitting up or reflux or regurgitation is one, vomiting is another. So let's see how we can differentiate, right? So first we'll talk about what regurgitation is. It is also known as reflux or gastroesophageal reflux. And what happens is there is backward flow of stomach contents into the esophagus. So either the stomach has to be very full, then it will effortlessly flow. And also the esophageal sphincter should be open. So many babies, you can see here that almost all babies will regurgitate or spit up after a feed. It is there in 65% of healthy infants, but decreases to 1%. Can anyone tell me why it decreases to 1% by 1 year of age? What do you think? Ashan, what do you think? You can guess. What do you think happens? Why does the number of children who have a reflux decrease by 1 year? Sorry, what? Can't hear.
Don't know, man.
Don't know. Think. I'm asking you to think. Yes. But do you think something happens with the stomach? What are the requirements for things to flow back? Either the stomach has to be full, and for it to flow into the esophagus, are there any sphincters in the esophagus, the lower esophagus?
Yeah, lower esophageal sphincter.
Yeah. So what do you think must be happening to the sphincter? When will the things flow easily? If the sphincter is like relaxed, or if the sphincter is tight and strong?
Tight and strong.
If it's tight and strong, can things flow easily or difficult?
No, if it's tight and strong, it can't flow easily.
That's right. So do you think that there may be something, maybe what if the sphincter strengthens? Maybe it's weak in the younger baby, and if it strengthens with age, then the reflux will be reduced, isn't it? So let's see why the reflux reduces. So this is again another picture. It's very, very common, right? With small babies, they spit up milk, and it's a problem for those who care for them. So why is regurgitation common? One thing is that their stomachs are small. So when the stomach is small, it can be easily distended and easily it can become full. And the other thing is that the lower esophageal valve is immature, right? But with age, the lower esophageal valve strengthens and tightens, and with this, the spitting goes away, as well as the stomach will also grow in size. If you remember during the nutrition growth and development module, we said that stomach is like the size of a cherry as soon as they are born, and only by 1 month the stomach is the size of an egg, right? But with age, stomach will grow. So with that, the stomach will get bigger and the esophageal sphincter will get stronger. So with that, the spitting up or the reflux will get better. So there are some babies in whom regurgitation is more than in others. So in such people, what do you think would be the effective measures? Dilhani, you can think and say, you don't need to know. I just need you to think. Now you know the mechanism. From a full stomach, it comes up, right? So what are the things that might help with minimizing regurgitation? Dilhani? Yes, Dilhani. What do you think? Deshan?
Feeding the baby upright position.
Yes, very good. Feeding the baby in the upright position, right? So rather than keeping the baby flat, keeping the baby upright, what will help, Deshan? The gravity will help, right? To keep the things down. So these are some pictures. If you're carrying the baby, carry it in the upright position. If you're sitting the baby, you can sit it up, and effective burping technique or winding, as well as putting the baby prone on the legs and burping. So you might have heard the word burping, which is a lay term, or winding the baby. When the baby swallows milk or when the baby is sucking in milk, if the seal is not perfect at the breast, along with swallowing the milk, baby will also swallow in air, and this air will take up space, right? And I'm sure you have all experienced bloating of the abdomen for yourself, right? So if you lie prone and the tummy is pressed, or somebody presses the tummy for you, it will help the air to go. That is the basis behind burping, right? But for us to compress the tummy and send out the air, the tummy should compress on top of a bony prominence. So when you are carrying the baby, for a male it is okay, but for a female, because of the breast tissue, carrying the baby upright is not the ideal position to burp, because the tummy should be where the clavicle is, and that is difficult to achieve in a baby who does not have head control. So in a small baby, especially newborn, the third method is easier. When the baby grows up, it's okay to carry the baby upright like in the first picture, right? In small babies, you can see keeping the baby skin to skin, keeping the baby upright also will help. Keeping the baby in the prone position will help the baby to reduce regurgitation, also to remove the air that is swallowed. Right. Can someone tell me what this picture shows?
Milk ejection.
Very good. It shows forceful eject. So usually it's not like this, right? But there are some women where the milk ejection is very forceful. So it's coming like you're putting a hose and directing the water into the mouth. So it's a forceful spray. So what can be the problem? This is called forceful ejection of milk. What can be the problem? Imagine if I keep a hose and try spraying inside your mouth, what will happen?
Aspiration.
Yeah, it depends on whether you can swallow at the speed I'm spraying or not. No, either way, it's not a pleasant experience if you can't control it. So baby will not like this. He will cry and he will get away from the breast, right? You can see. Because one thing is there can be aspiration also. If the baby is unable to swallow at the speed, this milk is being ejected. So what do you think we can do about this? Usually this forceful ejection is at the start of the feed when the breast is very full. So in these situations, we tell the mother to express the first part of milk. As she expresses and the breast becomes more and more empty, this force reduces. And this spraying kind of thing stops, and it becomes normal, and it just starts to drip from the breast, which is easier for the baby to take. So if we find there is forceful ejection of milk, we ask the mother to express and remove the first part of the milk until this force of the spray is markedly reduced, where there is no spray and milk is only coming out of the breast, but not sort of, going on like a projectile. At that point, we ask them to feed. How do we recognize it clinically? What the mother will tell is the baby is sucking at the breast. After a little while, or few seconds or few minutes after starting, baby cries and baby pulls away. And this sort of mother will have lot of milk or little milk. What do you think the weight gain will be in the baby? Good weight gain, poor weight gain? Will the mother feel that there is lot of milk or little milk? Deshan?
Mother has lot of milk.
Exactly. Mother will have lot of milk, and what can we expect about the weight gain of the baby? Will this one be like a very failure to thrive, poor weight gain baby, or good weight gain?
Good weight gain.
Yes, sometimes massive weight gain, right? So because this one will have enough milk, mother will have lot of milk. She will say that she has the let down reflex. That is when feeding from one side, milk is pouring from the other breast as well. Baby will have a good weight gain. And the classic story will be baby starts feeding. After a few seconds or minutes, baby starts to cry and pull away, right? So if that is the case, you must check whether baby is having good weight gain. Mother is saying that there is enough milk, and in that history, how we can reduce the discomfort in this situation is we ask the mother to express until this forceful ejection is reduced. So milk is coming only out of the breast, and then we ask the mother to give the baby the breast at that time, right? So offer only one breast per feed and attach the baby to the breast after expressing the forceful spray once the flow has subsided. Right. Then another thing that can cause problems are what can cause baby to regurgitate is sometimes products in the mother's milk can be allergic to the baby, rarely. Right? It can even be cow's milk in the mother's diet, or there can be acidic food like tomatoes, fruit juices, processed fruits, caffeinated foods in the mother's milk, chocolate, high fat foods, spicy foods. But this doesn't mean every mother has to avoid these foods. But if your baby has a problem and has regurgitation, after excluding the common causes, what we talked about, right? If the positioning is not working, if there is no forceful ejection of milk, then you have to think about whether there is something in the mother's diet. And removal of this product will resolve the situation. Then the next thing is when we have to recognize when regurgitation or reflux is pathological. Right? So most of the time it's harmless. It's just a nuisance because the baby will be spitting up stuff on your clothes. You're ready to go somewhere and your clothes are ruined, something like that. So you need to take precautionary measures. That is why you might see that sometimes parents of newborn babies have a special sort of a bib cloth or something to protect their clothes. But other than that, it's not a big deal. But there are instances where it's a problem. So what are the red flag signs of regurgitation? Right? So either the baby is not having enough weight gain, or there is features of esophagitis, meaning it might be painful for the baby, or the regurgitant or whatever the vomiters may contain altered blood or blood, right? There can be baby may be getting recurrent respiratory symptoms because of the contents going into the respiratory tract, either getting wheezing or pneumonia. And the baby may have oral aversions. They may not want anything in the mouth because of the acidic content that is coming into the mouth. It may be a very unpleasant experience for the baby. So these babies will cry soon after feeding. You will see that they are having reflux, they cry. They may have blood-stained vomiting. They may have frequent respiratory infections. They may have poor weight gain. So if any of these things are present, that means the regurgitation is pathological. It means it needs treatment and it will need further evaluation. So this is not common. You can see that it occurs in 1 in 300 infants, and it's commoner in children with neurological impairments. Can you see how the neurological impairment adds in? It's because if there's a neurological impairment, that means control of the stomach emptying may be slow. So things will be accumulating in the stomach, predisposing it to overflow into the esophagus. Also, the esophageal sphincter is under neural control. So if there's a neurological problem, the sphincter also may not be working well. So due to these things, these problems are more commoner in children with neurological impairment. So if there are features suggestive of pathological regurgitation, we need to treat it, right? So there is a medical management as well as a surgical management. We can reduce the volume of feed per feed and give it more frequently. And if it is painful or blood-stained, we have to think of reducing acid secretion, neutralize the acids by using either antacids, H2 receptor blockers, or proton pump inhibitors. We can use use agents to increase the gastric emptying, like erythromycin or feed thickeners, right? So only if it is having pathological symptoms. If there are no red flag signs, if the regurgitation is not pathological, it does not need any of this treatment. If the condition does not respond to medical treatment, we must consider fundoplication, which is a surgical treatment for pathological regurgitation. Okay. So let's try to do a question to see whether you got what I'm saying. Gunaratna 115. Okay. Yes. What do you think? Regurgitation in neonates is a common phenomenon. But true or false?
True.
Good. Right. Tarusha or Tarusha Vijayasekara. Due to immature lower esophageal valve. Is that correct? True or false?
True, madam.
Okay, then who else? Bogoda 1119 considered pathological in the presence of poor weight gain. Bogoda. There. Serena MAF 1264. What do you think about C?
True, madam.
True. Okay. Chandra Siri. What about D? Rhea in babies with neurological impairment. False. Okay. And okay. And then Shanya. Improved when baby is kept upright position, in the upright position. Shanya Mudannayaka.
Yes, madam. Is it E?
Yeah. True or false? E is true or false?
It's
Shanya.
true.
True. Okay. All
True,
right.
madam.
Okay. Okay. Thanks, Shanya. Good. You're correct. So you all answered well. So you have been listening. Well done. So other than D, all the other things are true. Okay. So let's look at another question. Features of pathological regurgitation in neonates include. Who's next? Samiha. What about A?
True, madam.
True. Okay. Sanjayan B.
True, madam.
True. Radesh C.
True, madam.
True. Okay. Osanda. Bloodstain vomitus D.
True.
True. Okay. And the person above Radesh. Randula. Nuvani. Netsarani. E.
True, madam.
True. Okay. So let's have a look. All right. So well done. All spitting up B true කියලා කිව්වද කවුරු හරි? Features of pathological regurgitation in neonates, right? Poor weight gain is true. Spitting up after most feeds is not true. That is not a feature of pathological regurgitation, right? That happens in all the babies. Irritability is true because of the pain. Bloodstain vomitus is true because of the damage due to the acid reflux, and oral aversion is true again because of the acid taste in the mouth. Any questions up to here? Anything not clear? Anything you want me to go through again? Okay. If not, we are going to move on to vomiting, right? So the main difference between reflux and vomiting is reflux or regurgitation is a passive thing, right? There is no active participation in the baby. It's just that either the stomach is full or the lower esophageal sphincter is not working very well. So let's move on to what is vomiting. Vomiting is gastric contents are coming out of the mouth, right? And this is due to reverse peristalsis in the small intestine. So I'm sure you have already learned how vomiting occurs, right? That it occurs through stimulation of the vomiting centers, right? And it can have many ways of how that happens. It can be the chemoreceptor trigger zones in the fourth ventricle. which may be due to raised intracranial pressure, toxins, or drugs. It can be the vagus nerve in the pharynx. It can be the vestibular system, either due to cerebellar or ear pathology. It can be GIT irritation, or it can be stress and psychiatric conditions having an effect on the CNS. I'm also quite sure you have gone through the consequences of vomiting, right? So when you vomit, you are basically putting out acidic fluid, right? The acid in the tummy is going out. So in that case, what happens? You will have problems of fluid depletion, that is dehydration, right? And if the stuff are not being absorbed into the body, there will be malnutrition. If it goes in the wrong path into the respiratory tract, because you know the trachea and the esophagus are close to each other, there can be aspiration and aspiration pneumonia. Then loss of acid can cause metabolic alkalosis. Again, you also know that stomach fluid is rich in potassium, and if that is lost, it can cause hypokalemia, right? So you should be able to, you should know what are the consequences of vomiting and also the mechanism of how each of these happen, the pathogenesis. Then we are moving on to something specific in the newborn, right? So newborn, as you say, it's in clinical situation, mother will say baby is throwing up, right? It's difficult to know whether it is regurgitation or vomiting. So whatever the situation, the red flags will include the below, right? So if there is blood, if it is altered blood, if the blood is reacting with the hydrochloric acid in the tummy, the vomiters will be stained black. If there is fresh bleeding, that is before it contacts the stomach, then it will be red. So bile stain vomiting can be green or yellow, more towards green. Projectile vomiting, you saw, just like the projectile milk, the forceful ejection of milk, vomiting can go like a projectile. The baby can be sick. There can be poor weight gain. There can be fever more than 38 Celsius. There can be diarrhea or abdominal distension. So any of these signs indicate that the baby is sick and warrants urgent investigation and treatment. Right. Maheshi, can you tell me, what does this picture show? What sort of vomiting is this?
It's a blood-stained vomiting, madam.
Yes, very good. So this is a picture of blood-stained vomiting in a newborn. This is the kind of things that mothers show. This is a stain, right? This is kind of a brownish reddish mark. Good. So why do babies have blood-stained vomiting? The commonest cause is swallowed maternal blood. But for that baby, it's likely that the baby is born via vaginal delivery, right? If the baby is having a cesarean, born via cesarean section, that is unlikely that they come into contact with blood. But if they are being born through the vaginal route, all the blood that is there in the vaginal route can be swallowed. Also, can you think of another way baby can swallow maternal blood? One is at the time of birth. What is the other way? Kirtana.
Yes.
What is the other way? Anyone else who can think of it also can say, Kirtana, what do you think? Either it's from the mode of delivery, so the vaginal route, or
Maybe any hemorrhages within the
where? Hemorrhages where?
in breast milk.
Yeah. Why they are bad in the breast milk? So the mother can have, let's say, a bad crack nipple. And if there is any bleeding at the crack nipple in the breast when the baby is feeding, baby may swallow blood during breastfeeding also. Very good. So either it is during vaginal delivery or when the baby is feeding. So if you think that swallowed maternal blood, you must also examine the mother's breast to see whether there is a cracked nipple and whether there is any bleeding from there which the baby might have swallowed. Or in the history, you must see whether the baby was born via vaginal delivery. Then swallowed maternal blood may be the problem. So it is not always swallowed maternal blood. There can be issues that the baby itself is bleeding, in which case the commonest cause would be, the next common one is hemorrhagic disease of the newborn. So Sandaruvan, can you tell me what is the nutritional deficiency behind this hemorrhagic disease of the newborn? Have you heard this word before? Sandaruvan 1249. There is someone called iPhone. You must put your name, otherwise difficult to find. iPhone, can you answer?
Vitamin K deficiency.
Very good. Vitamin K deficiency. Why don't you rename yourself? Okay, so that is also another problem. So it's important sometimes you all get confused. Hemorrhagic disease of the newborn is different and it's due to vitamin K deficiency and it results in bleeding in comparison to hemolytic disease of the newborn, right? What we did under the BLS, right? That is the problem of anemia, hemolytic anemia diseases, but the names sound alike. So sometimes you all get mixed up. Right. So the other thing is baby can be very stressed and there can be stress ulceration if the baby is extremely sick. And swallowed baby blood is if you have tried any oral procedures, like you may have tried to intubate and the laryngoscope may have caused a baby's mouth. So it can be the baby's own blood that is swallowed, and reflux, which we talked about earlier. Right, so the commonest cause is swallowed maternal blood, but the next common thing you must remember is hemorrhagic disease of the newborn. So what does this picture show? What is this test which is used to differentiate swallowed maternal blood from baby's own blood? Have you come across any test like that? Now we said it may be the mother's blood that the baby has swallowed, right? So if we take a sample, we can see whether it's mother's blood or baby's blood, or whether there was any swallowing. Does anyone know what the name of this test is, which we are trying to differentiate between maternal red cells and baby's red cells? No? Okay. So this is called the AP test or alkaline denaturation test. The base behind this, the baby's red blood cells have a high concentration of fetal hemoglobin. The fetal hemoglobin, baby has 70% of fetal hemoglobin, and the fetal hemoglobin is alkali resistant. So when you put alkali into the blood picture, mother's red cells are destroyed, baby's red cells are, right? So in that situation, what you can see is the ghost cells, or the light colored cells are the mother's cells, and the dark red color cells are the baby's red blood cells, which have not been destroyed. So by counting, you can see whether there is more swallowed maternal blood, or actually the baby itself has bled. Right. So moving on from blood-stained vomiters. So in that, you need to remember what are the causes of blood-stained vomiting, and how do we differentiate whether the baby has swallowed maternal blood or whether it's baby's blood or the baby is bleeding him or herself. Right. So what type of vomiters is this? Induranga? Induranga again there.
Bile stain vomiting.
Bile stain vomiting, very good. So this is the green color vomiting we are talking about. So if you see something like this, you must remember it's a red flag sign. You don't say "Ai parak mama nidanaka balamu kiyanne." You have to immediately investigate this, right? So if there is bile stain vomiting, it is considered as intestinal obstruction until proven otherwise, right? So the most dangerous situation is volvulus in malrotation of the midgut, right? And intestinal obstruction distal to the ampulla of water will cause bile stain vomiting. Can someone tell me how to address this? How do we treat? You may have had, did you have the lecture by pediatric surgery on surgical conditions in the newborn? Did you have it or not? Most probably you have had, no? Because my lecture is a little late. Hey Yantudua, did you have the lecture on from pediatric surgery?
No, madam. Not yet,
No?
madam.
Not yet. Okay. Then think and tell. What do you think? Now we are suspecting. Now you have, mother has said baby has vomited. You have seen on the baby's clothes there's green color stuff. We are suspecting intestinal obstruction. What is the first thing you will advise the mother to do? Hasini, Hasini neda. Hasini Singha Kumara. What is the first thing you should advise the mother to do, Hasini?
Reduce feeding.
Reduce lemay, stop feeding, right? So good. Nil oral. You have to say keep nil oral and we stop feeding. So if we stop feeding, what else do we have to do? Harshana, what should we do next if we are stopping the feeding?
IV nutrition.
Very good.
Arrangement.
So we have to start intravenous fluids. Good. Then what else? Now the baby is having an intestinal obstruction. First thing is nil oral. Then if we are keeping nil oral, we have to give IV fluids. But now if the baby keeps, collecting stuff and starts pouring into the respiratory system, there can be aspiration. How can we prevent this? Viduli?
Nasogastric tube.
Yes, very good. We have to put a nasogastric tube. Now, if you think of the size of the nasogastric tube, Diduli, do you want to put the biggest tube possible or smallest tube possible in this situation for this baby?
Biggest tube.
Why biggest tube? You're correct. It is the biggest tube. Can you also tell why?
To prevent any source of aspiration.
Yeah, no, now there are two things now in NG tubes. You put NG tubes either to aspirate or take out the stuff. So if you want here, we want to quickly take out the stuff so things don't accumulate and spill over to the respiratory tract. So for that thing, if the tube is big, we can quickly pull out the stuff. So if the goal of putting the NG tube, like in this baby's aspiration, you must put the biggest tube possible. But NG tubes are also used to feed. Right, so if you are putting it for feeding, then you don't have to put a huge tube, right? But if it is for in intestinal obstruction, you have to put the largest tube possible. And then should you keep the end of the tube open or closed? Should you keep the NG tube, Safir? Should you keep the tube open or closed? End of the NG tube. Safir? Anuradhi, what do you think? Should we keep the NG tube open or open end? Open drainage, or should we close it with the cap? Anuradhi? Yamini? What do you think?
Open-ended.
Sorry?
It's open.
Yes, very good. It should be open and it should be kept open to a bag so that it drains out. Right? If you put the NG and close it, it won't help because all the stuff will still remain inside. We want to empty all the stuff that is accumulating in the intestinal tract so that it won't come and spill over to the, from the esophagus, it doesn't go and spill over onto the trachea. So wide tube, and it should be kept in open drainage. What else? So we have now kept nil oral, started IV fluids, and you have put a wide bow NG tube, kept it in open drainage. What else? S. Vijay Sekara, anything else we should do? You all have done surgical appointments now. Anything else now? Intestinal obstruction. Yes, Vijay Sekara, can you answer quickly, please? Vijay Ratna, HMN. What else needs to be
Madam,
done?
can I answer that?
Yes,
IV
please.
antibiotics?
Yes, excellent. What type? Can you also tell me what type of IV antibiotics we should give?
Anything broad spectrum?
We would generally go for something gram positive. So IV in newborns, we give penicillin and gentamicin because those cover the commonest organisms, right? So we should give a gram positive cover, which we give with penicillin, gram negative cover with gentamicin, and anaerobic cover with metronidazole, right? So IV antibiotics. So we have come up with 4 steps: nil oral, IV fluids, wide bow NG, open drainage, IV antibiotics. What else? We should also refer to the surgeons. No, after stabilizing the baby, we should refer to the surgeons. How can we make a positive diagnosis? But any investigations that will help us with diagnosing whether this baby is actually having intestinal obstruction? Vijay Nayaka SS?
X-ray of the abdomen.
Very good. X-ray of the abdomen. But you must remember now babies are not standing up, so we may not see fluid levels, but we may see is dilated bowel. And can you think of any other electrolyte abnormality which can cause a similar picture? Vijaya Sundar SU? Vijay Sundar SU? Any electrolyte abnormality? Or Vijay Ratna? WDGY? Can anyone think of electrolyte abnormality that can present like this? No? Okay, hypokalemia can present like this, so it's important that we take blood now. Before we give antibiotics, we have to obviously take a blood culture. At the same time, you can do a partial septic screen for full blood count, CRP, and look at serum electrolytes, right? Hypokalemia can cause paralytic ileus. I'm sure you have heard about it. So it's important to check potassium level, right? So if you look at this picture, can you identify the cause for intestinal obstruction in this newborn? Varusavitana CN, looking at the picture, can you see something that has caused intestinal obstruction in this child?
That spans have compressed the
Yes,
duodenum.
yes, correct. I'm sure you may have come across these things during embryology days also. So let's bands, if they are there, they can cause a compression like this and cause malrotation as well, right? And here, if you look at this, can you identify the cause of intestinal obstruction in this newborn? You can see dilated bowel loops, right? So you can try to see whether this is large bowel or small bowel and then assess. You can see that there is no gas in the bottom, in the rectal area, right? So clearly see there is, you don't see air fluid levels like you do in adult because this baby is not standing up, babies are lying down, but you can see very dilated intestine. So that will help you with the diagnosis of intestinal obstruction, right? So what are the features that we see? We can see dilated bowel loops. We can see absence of air in the rectum, and it does not show air fluid levels as babies are in the supine position. Okay, so can someone tell me, oops, what did I do? Can someone tell me what is the cause of intestinal obstruction in this baby? What are the buttocks of the baby that are shown? So this is actually showing an imperforate anus. right? So that is another reason why babies can have features of intestinal obstruction. This is an investigation that is done for babies with imperforate anus, right? This is called the lateral shoot-through X-ray, and it's usually performed after 24 hours of diagnosing because we should give enough time for air to enter the intestines. If you do too early, there will be no air in the intestines, and then you keep a probe on the buttock of the baby where you expect the anus to be, and you look to see what is the distance between the air bubble, the last bit of air seen in the intestine, and the probe, and you then determine whether it's thing called high imperforate or low imperforate anus. If the obstruction is lower down, the correction is it may be just breaking the pin that is causing the imperforate anus. But if it is a high imperforate anus, it will involve doing colostomy as well. So this is why this lateral shoot through is done 24 hours, at least 24 hours after birth, in order to determine what type of correction or treatment is needed for babies with imperforate anus. Right, so here are the answers to those questions. Right, so now we are moving on to a different type of vomiting, right? So we are coming on to projectile vomiting. Sorry, did I do? So at birth, the commonest reason for projectile vomiting is duodenal atresia. So if you remember now from your anatomy days, you must know at which point bile is secreted, right? So if the vomiting is bile stain, that means the obstruction is below that point, so distal to the ampulla of water. If the bile is not, if the vomiting is not bile stain, that means that the obstruction, if there is projectile vomiting, milk only, no bile stain, that means the obstruction is before the ampulla of water. So at birth, the commonest cause is duodenal atresia, but around 2 to 3 weeks of age, it is pyloric stenosis. So what can you see in this picture? How will you describe this X-ray? Vadurasa? Vadurasa 1289. Can you describe
Yes.
the X-ray? Yeah. Just tell me what you see. It doesn't matter if you don't know. What can you see?
Left side of the X-ray.
In the stomach, in the abdomen area of the X-ray, what can you see? In the left side, you started. What can you see on the left?
The stomach has been dilated.
Yeah, there is air fluid level, right? How many air fluid levels can you see here?
3.
3? 3 kohti. You can see 2. One is just near the stomach. Let me see how I can point. Okay, can you see? This is the first air fluid level. First this is the other one. There are 2 air fluid levels. So because there are 2 air fluid levels, this appearance is classically known as bubble appearance. Right, so double bubble appearance is suggestive of a pathology in the proximal duodenum. It is presenting soon after birth, it should be duodenal atresia. If it is presenting later, it can be duodenal or right. So this double bubble appearance is characteristic of either duodenal atresia or duodenal stenosis, and this is also associated with another syndrome. Right, it is associated with Down syndrome. So if you see this in a baby, you have to carefully look and see whether the baby has features of Down syndrome. Now, moving on to pyloric stenosis. So pylorus, what we mean by pylorus is, if you revisit your knowledge on anatomy of the stomach, that is, this outlet of the stomach is known as the pylorus. This is the pyloric area. So here, this is genital hypertrophic pyloric stenosis. So there is a hypertrophy in the wall of the pyloric, and thereby it blocks the outlet of the stomach. So if it blocks the outlet, there won't be any bile stain, but all the stuff here will get blocked, and there can be projectile. So just like in an adult gastric outlet obstruction. Right, so this picture shows you some other stuff again. What clinical sign is demonstrated in this baby, right? Can you see this? This is called visible peristalsis. So when you look at the baby, you can see peristaltic waves going, and that is a classical feature of pyloric stenosis. Right? So this is a picture of where you see visible peristalsis. Okay. So pyloric stenosis is a form of gastric outlet obstruction, and we talked about it. So from what we have talked about it, let's see whether you can answer this. Baduge, what are the features of pyloric stenosis? What about A? Do you think metabolic acidosis will occur?
Yes, it may occur.
What type of fluid is there in the stomach?
The stomach fluid is acidic.
So if you now with projectile vomiting, you are going to lose stomach fluid, no?
Yeah. So
What fluid, what will you get?
an alkalosis.
Alkalosis. So this, I don't think this is correct. A should be wrong. Then what about B? Udayakanta, what about B?
True, madam.
True. Why is it true, Udayakanta? Explain.
The gastric content contain more potassium.
Very good. Yes. And with the projectile vomiting, if you lose high potassium fluid, you are likely to become hypokalemia, right? Okay. Good. Then what about C? Tipikaran?
True, madam.
Okay, but now we talked about this now. Pyloric stenosis does not present at birth. It presents after weeks of birth, right? So therefore it is false. That is a bit of knowledge. You can't really, unfortunately, work it out. But in the pathogenesis, it says that it is the reason why pyloric stenosis happens may be a reaction to some environmental stimuli. So it does not present at birth, but it presents 2 to 3 weeks after birth. Right. Then, is it bile stain? Tatsarani? Is D correct? Tatsarani WBDD 1274? What about D? Is bile stain vomiting a feature of pyloric stenosis? Subodhini?
False, madam.
I can't hear, sorry, Subodhini.
False, madam.
Bile stain is false. Why?
Because it's proximal to alveolar fluid.
Right, okay. And E, who's next? I think LAP Silva. E, is visible peristalsis seen in pyloric stenosis?
Yes, madam.
Right,
True.
okay. All right. So metabolic acidosis is false. Oops. Why is hypokalemia false? I think that should be wrong. Presence at birth is false. Bile stain is false. I think hypokalemia should be true. I think I have made a mistake there. Visible peristalsis seen is true. Then vomiting with diarrhea. We are moving on to another area. So until proven otherwise, we assume this to be gastroenteritis. Right? It is uncommon in exclusively breastfed babies. I hope you remember all the things we did about breastfeeding for the nutrition, growth, and development module. We said that gastroenteritis is, I think, 64% less. So it's very uncommon to have a diarrhea in exclusively breastfed baby. Then dehydration and shock can occur. So it's your main focus is preventing dehydration, right? So that is with continue the breastfeeding. Depending on the degree of dehydration, you may need oral rehydration salts. If it is severe dehydration, IV fluids, you may need stuff to stop the vomiting, either oral or suppositories of antiemetics. That is where domperidone comes in. Right, then vomiting can be in a sick baby with fever. So if there is a sick baby with fever, we have to think it is infection until proven otherwise. So then you have to see which system is involved. If there is cold and cough, post-acid vomiting, it can mean this is a pneumonia. If it is excessive crying, bulging eardrum, it may be an infection. If it is crying after or during micturition, not before crying before micturition is a normal phenomenon in babies. When the bladder gets full, they cry for the discomfort. They are crying after passing urine or during micturition, that might mean they are having dysuria. Then bulging fontanelle, irritability, drowsiness, right? Any form of neck stiffness, not in the smallest babies you can't detect, those may mean meningitis. So the most important part, if it presents with vomiting and fever, what will be the most important part of the management here? Whatever the infection. Abe Surya BMV?
IV antibiotics.
Very good. So after doing a partial septic screen, so full blood count, CRP, blood culture, you have to think of the appropriate antibiotics depending on the system that is involved. Good. So then we are moving on to another category, vomiting in the unwell baby without fever, right? So UTI can present either with fever or without fever. If it is pyelonephritis, most probably the baby is very sick with fever. But if it's a lower tract urinary infection, they may present without fever. We also talked about, now while we were talking about why vomiting occurs, increased intracranial pressure, hydrocephalus can cause vomiting. Then congenital adrenal hyperplasia and other inborn errors of metabolism cause vomiting. So Seniviratna, what do you think this picture is showing? What is the most likely cause of vomiting in this baby? Seniviratna TACM?
Hydrocephalus.
Very good, hydrocephalus. You can see the large head, the prominent veins, the sunset eyes. So gross hydrocephalus if not shunted, right? In a shunted baby, so in some babies a shunt may have been inserted to drain the hydrocephalus, but by any chance if the shunt is blocked, that can also cause vomiting. Also, if there is a shunt, there can infection. Any plastic device inside our body is prone to infection. So a blocked shunt, infected shunt, or non-shunted gross hydrocephalus, all of these things can cause vomiting. What is the most likely cause of vomiting in this baby? Oh, wait. Trying to move the name. R.S. Seniviratna. What have I done? What is the most likely cause of vomiting in this baby?
Urinary tract infection.
No. What has urinary tract in? Look at the genitalia carefully. This is ambiguous genitalia. Can you see the scrotum is divided into two? The phallus is not very clear. It looks like kind of a, but it's not very clear. So this is a picture of genitalia, right? Congenital adrenal hyperplasia. You must remember what you learned in endocrine module. Please go through that. So one of the present features of congenital adrenal hyperplasia is in a child with ambiguous genitalia. thing with vomiting. So this is a picture of ambiguous genitalia. Okay, so vomiting with failure to thrive or poor weight gain can be due to gastroesophageal reflux disease, into urinary tract infection, or inborn errors of metabolism. Right? So in summary, we talked about vomiting, we talked about regurgitation, the difference between them. We also talked about physiological and pathological regurgitation. We talked about how to overcome physiological regurgitation, right? By keeping the baby upright, burping the baby, and if there is forceful ejection of milk, expressing the first bit of milk, and looking to see if whether there's any allergens in the mother's diet, removing them. And we looked at what are the red flag signs for pathological regurgitation. We discussed the medical and surgical management for pathological regurgitation. Then we talked about what vomiting is, the mechanism of vomiting, the different areas which stimulates vomiting. Then we talked about the red flag signs, the causes, and the management. Okay, so we are done. Any questions? So some questions had. Somebody asked, why would you close it? Because there is a stopper on it. Some people close it, but you should not close it, because if you put it in for feeding, you don't want germs to come in. So if you put it in for feeding, once you feed the baby, you flush the NG tube and you close it. But if you put it for aspiration, you obviously should not close it. It should be kept open and in open drainage. Kleihua-Betke test is also the same or similar. I'm not sure whether it's exactly same thing, but it has a very similar principle. It may be another name for it, or it may be slightly different, because there is one with acid resistant, one is alkali resistant. So you please read about that. Any other questions that you have not put in chat? I think we need to finish as well, because it's 11:30. You might be having something else at 11:30 also, I think. Not sure. Any questions? Okay, if there are no questions, we can finish.
Thank you, madam.
Okay.